of the day. I am Dr. Shweta Bawari from Pharmacy Institute, Noida Institute of Engineering and Technology, Greater Noida. In this lecture, I am going to cover the topic pathophysiology of stroke and psychiatric disorders. Beginning with pathophysiology of stroke. Stroke is a condition of reduced blood flow and eventual oxygen deprivation to brain, leading to the death of the brain cells. So, when there is reduction in the blood flow to any organ, in this case brain, there will be oxygen deprivation, and when the cells are not receiving oxygen, it will result in their death. So, based on the severity of the part of the neuronal damage in the brain, stroke may result in numbness in face, arms or legs. It may result in coma. It may result in hemiplegia, which is paralysis on one side of the body. It may result in speech impairment. It may result in sensory impairment, means difficult visual impairments, hearing impairments, etc. So, it basically depends upon which part of the brain is not receiving proper blood supply, and there is oxygen deprivation, which ultimately results in the death of the brain cells. So, which part of the brain is affected? So, based upon that, which cells have died, the symptoms occur. The two major variants of stroke are ischemic stroke and hemorrhagic stroke. In ischemic stroke, the blood flow to the brain is affected by narrowing of vessels due to atherosclerosis and eventual thromboembolic events. So, what atherosclerosis is basically? When I am talking about ischemic stroke, in this there is reduced blood flow to the brain. How? Because in certain blood vessels that are supplying to the brain, there is deposition of there is atheroma formation, there is atherosclerosis, there is deposition of the cholesterol. Now, when in the blood vessels, when there is deposition of the cholesterol, the lumen of the blood vessels is reduced. So, the blood supply to a particular region is also reduced, and when the blood is not being supplied, that will also result in reduced oxygen supply to that particular region of the brain or to those brain cells, resulting in their death. And when I talk about thromboembolic events are when there is atherosclerosis, when there is plaque formation, the plaque are formed by cholesterol. So, when they dislodge from their site where they originally were, present, they are sticking on the blood vessels. So, when they eventually dislodge, they start moving in the blood vessels. Now, when the lumen, the diameter of the blood vessel is wide open, they can move easily, but there will be a certain point, like they may go and lodge into a capillary where they will obstruct the capillary. Now, when any blood vessel is obstructed, a capillary is obstructed, that means the blood supply to that particular region of the brain will be restricted. There will be no blood supply in that particular region of the brain, ultimately resulting in reduced oxygen supply and death of the brain cells. So, this is ischemic stroke, which basically occurs due to atherosclerosis and thromboembolic events because of the deposition of the cholesterol plaques. Then we talk about hemorrhagic stroke. When I talk about hemorrhagic stroke, this stroke occurs due to blood loss. When there is any injury, there is brain tissue injury, when there is trauma, or in the case of severe stress, or where there is abrupt rise in BP, which results in the rupture of the blood vessel. Any of the condition that can result in the rupture of the blood vessels in the brain, whether it be brain tissue injury, whether it be excessive stress condition, excessive rise in the blood pressure, it can result in the rupture of the blood vessel in the brain. So, in that condition, what will happen? The blood will ooze out. It will come out of the blood vessels and will not be supplied to the blood cells. Now, when the blood cells are not receiving any, the brain cells are not receiving any blood supply, they will be deprived of oxygen supply also, and when there is no oxygen received by the cells, it will result in their death. So, this is hemorrhagic stroke. Now, coming to the pathophysiology of psychiatric disorders. Psychiatric disorders are the disorders that affect mental health. These are the heterogeneous group of disorders including depression, anxiety, schizophrenia, alcohol or drug abuse, dementia and autism. So, all these disorders basically these are the disorders, these are the diseases that in one way or the other are affecting the mental health. So in this particular lecture, we are going to focus on depression and schizophrenia, these two forms of psychiatric disorders. Beginning with the pathophysiology of depression. Depression is a potentially life-threatening disorder with symptoms ranging from low or depressed mood, loss of interest or pleasure, significant weight or appetite alteration. When I talk about alteration, there can be significant increase in the weight and hunger. Means there can be an eating disorder where a person wants to eat more and more. This type of depression can be there, and there will be sudden increase in weight also, or the weight can abruptly decline, and there can be reduced appetite also. The person doesn't feel like to eat anymore, and there is abrupt decline in the weight. Insomnia or hyposomnia. Insomnia means absolute deprivation of the sleep, and hyposomnia is reduced sleep pattern. Psychomotor agitation or retardation. There can be psychomotor alterations, there can be agitation or retardation. When I talk about psychomotor retardation, it means that the person afflicted with depression might in the retardation state might like to sit in a corner somewhere, doesn't want to respond to any of the stimulus. And when we talk about psychomotor agitation, the person might be restless, moving to and fro in the room, would be either hitting the wall. These kind of symptoms can also occur. So agitation and retardation both. Fatigue or loss of energy. Feeling of worthlessness is a hallmark of depression. Diminished ability to think or concentrate. There is certain indecisiveness, and suicidal ideation is also very common. Suicidal thoughts are very common in depressed patients. The two major variants of depression are unipolar depression and bipolar depression. Now focusing on the term unipolar. So unipolar depression, in which the mood swings are always in the same direction, accounting for major episodes of depression. This means that in unipolar depression, the person is only depressed. Okay, there are no other type of mood swings. The mood swing which occurs is only the depressive state. The person remains continuously and persistently only in the depressive state. But on contrary, when we talk about bipolar depression, as the term suggests, bipolar, so in which depression alternates with mania characterized by impatience, aggression and impulsive actions. Means that there are episodes of depression that continues for a particular time period, then it is alternated by, or it is followed by the episodes of mania, where there will be impatience, there will be aggression, there will be impulsive actions. Then again, after a certain period of time, there will be again a depressive state, and then again this can be followed by the episodes of mania. So this is a bipolar depression. Monoamine hypothesis of depression. When we talk about the pathophysiology of depression, how it occurs, monoamine hypothesis of depression is the most widely acceptable hypothesis. According to monoamine hypothesis of depression, it suggests that depression basically occurs due to the functional deficiency of norepinephrine, 5-hydroxytryptamine and dopamine in the brain. There is the deficiency in the functions of these three neurotransmitters: norepinephrine, 5-hydroxytryptamine and dopamine. This hypothesis is based on the fact that noradrenergic, serotonergic and dopaminergic neurons project to large areas in the brain, and they regulate a broad range of brain functions, including mood, attention, reward processing, sleep, appetite and cognition. So based upon this monoamine hypothesis of depression originated, because this norepinephrine, serotonin, 5-hydroxytryptamine and dopamine, they control a lot of brain functions, and they are spread in the large areas of the brain as well. Abnormal function and behavioral consequences of depression may arise from altered synthesis, storage or release of these neurotransmitters, as well as from disturbed sensitivity of the receptors. There can be either, like there is altered synthesis, means the synthesis or the production or the storage of these neurotransmitter, or the release of this neurotransmitter may be reduced, or there can be reduced sensitivity of the target organ or the target receptor to the effects of the functions of these neurotransmitters. Evidence for this monoamine hypothesis of depression arises from the following. Tricyclic antidepressants like imipramine block the reuptake of norepinephrine and 5-hydroxytryptamine and thus produce antidepressant effect. Now, for this I would like to show this figure. You can see the figure on the right hand side, the mechanism of action of tricyclic antidepressants. Whenever a neurotransmitter is released from the presynaptic neuron, from the axonal terminal, any neurotransmitter, when it has shown its effect, it has bound to the receptor either on the postsynaptic neuron or on the target organ. When it has shown its effects, the ultimate fate of any neurotransmitter is either it will be destroyed by enzymes like monoamine oxidase, or they will be taken back by the presynaptic neuron. They will be taken back up inside, which is known as reuptake. So, tricyclic antidepressants, they act how? They basically inhibit the reuptake of these neurotransmitters back into the presynaptic neuron. So, when the reuptake is inhibited, okay, when this reuptake is inhibited, these neurotransmitters, here we are talking about norepinephrine and 5-hydroxytryptamine, they reuptake back into the axonal terminal or the presynaptic neuron is halted, it is stopped. So, when this is blocked, they remain for a longer period of time in the synapse. Now, when they are for a longer period of time in the synapse, they can act repeatedly on their receptors and they can produce the effect. What is the effect produced? That is antidepressant effect. So, this suggests that it was due to their deficiency the symptoms of depression were occurring. Okay. Then the second thing is monoamine oxidase inhibitors block the destruction of released norepinephrine and 5-hydroxytryptamine and thus produce antidepressant effect. When there is a destruction of norepinephrine and 5-hydroxytryptamine, then also depression occurs. So, when monoamine oxidase inhibitors are given and the destruction of these neurotransmitters is inhibited, then also the symptoms of depression are ameliorated. Then dopamine reuptake inhibitors like nomifensin also block the reuptake of dopamine and thus produce antidepressant effect. Moving ahead to pathophysiology of schizophrenia. Schizophrenia is also known as split brain. So, schizophrenia is a psychotic disorder which is characterized by hallucinations. Hallucinations are basically imagining things that are not present. Like for example, a schizophrenic patient or a person who is suffering from schizophrenia is sitting in an isolated room, okay, in an empty room, may hear sounds, may see a person or a ghost in that particular room. So, this is what hallucination is, and it is a hallmark of schizophrenia that they can imagine things that are not, they are imagining things that are not actually present, like the presence of a ghost, like hearing voices, that is hallucination, that are not actually present in reality. Delusions, this is again a hallmark of schizophrenia, and what delusions basically mean is these are false belief about something. For example, if a person suffering from schizophrenia hears certain voices or hears people, two people talking, he may imagine, he may have a strong belief that these two people are talking about, they are conspiring about killing him or her. Okay. So, there are false beliefs, this is known as delusion. So, hallucination and delusions are two hallmarks of schizophrenia. Apart from this, there also occurs disturbances in thought, perception and behavior. Schizophrenia is a chronic psychotic disorder that disrupts the patient's thoughts. The illness commonly interferes with patients' ability to participate in social events and to foster meaningful relationships, because the patient has false beliefs. The patient can hear and see things that are not actually present. So, this results in detachment from the society. Okay. Then traditionally, the symptoms of schizophrenia have been divided into two main categories: positive symptoms and the negative symptoms. Now, when I use the term positive symptoms, it means there is an excess of the atypical behavior. When I use the term negative symptoms, there is suppression of, there is reduction in the normal behavior. Okay. So, the positive symptoms of schizophrenia include hallucination that I just discussed, delusion and thought disorders. The negative symptoms of schizophrenia include poverty of speech. There is no proper speaking, the person cannot properly speak. Then anhedonia. Anhedonia is inability to gain pleasure from normally pleasurable experiences. Like for example, the person cannot gain pleasure by talking to friends, cannot laugh on, doesn't find the jokes funny. So, these type of things, this is anhedonia. And there is also a lot of lack of motivation in the people suffering from schizophrenia. The neurochemical abnormality hypothesis, when we talk about the origination or the pathophysiology of schizophrenia, we talk about neurochemical abnormality hypothesis. According to this neurochemical abnormality hypothesis, schizophrenia basically occurs due to the excessive functional activity, the excessive functional activity of dopamine, norepinephrine, serotonin and deficiency, functional deficiency of glutamic acid. So, the dopamine hypothesis of schizophrenia is derived from two observations. First, the potency of standard antipsychotic medications correlates with the amount of dopamine D2 receptor blockade. This suggests that means when there is excessive amount of dopamine, it may result in schizophrenia. So, when we give D2 receptor blockers, the drugs that can block the dopamine D2 receptors. When the D2 receptors are blocked, dopamine cannot act. When dopamine cannot act, this means it cannot produce the schizophrenic symptoms. This confirms that dopamine, the overactivity of dopamine is involved in causing schizophrenic symptoms. Therefore, when we block the D2 receptors, there is amelioration of the schizophrenic symptoms. Second, drugs such as amphetamine, which enhance dopamine activity, can cause psychosis or exacerbate the schizophrenic symptoms. Now, again, when we administer drugs like amphetamine, which can enhance the dopamine activity, so in that scenario, what happens? The worsening of the schizophrenic symptoms occur if we administer them to the schizophrenia patients. If we give them to normal patients, in them also psychosis can occur. Psychosis means you can see hallucination or delusion like symptoms can occur in the people who are administered. In normal people, in normal healthy people, if you administer amphetamine, which can enhance excessively the dopamine activity. So, this can occur. The dopamine hypothesis holds that psychotic symptoms such as hallucinations and delusions are associated with the hyperactivity of dopamine in the mesolimbic system. Moving ahead to the serotonin and norepinephrine hypothesis of schizophrenia. According to serotonin and norepinephrine hypothesis of schizophrenia, it suggests that when there is functional overactivity of serotonin, 5-hydroxytryptamine, or there is functional overactivity of norepinephrine, this can result in schizophrenia. And this statement is basically derived from the fact or from the observations that when 5-hydroxytryptamine and alpha adrenergic receptor blockers are given, the receptors for when the receptors for 5-hydroxytryptamine are blocked, when the receptors for norepinephrine are blocked, it results in antipsychotic activity. Means the symptoms, the hallucination, the delusion will reduce when we administer the drugs that can block the receptors for serotonin and for norepinephrine. This has been seen, and that is why this serotonin and norepinephrine hypothesis of schizophrenia came forward. Similarly, the glutamate hypothesis of schizophrenia is centered on deficiency in activity of glutamate in the prefrontal cortex. This hypothesis means it suggests that, it says that when there is functional deficiency of glutamate, it results in schizophrenia symptoms. So, now how this hypothesis came into being? Based upon the observations, like the observations that NMDA receptor antagonist, when NMDA receptor antagonist, NMDA stands for N-methyl D-aspartate, and this NMDA receptors are receptors for glutamic acid. So, when the receptor antagonist or NMDA receptor blockers are when administered to normal healthy adults. So, like the antagonist, the examples for these antagonists are like ketamine, phencyclidine. When these drugs are administered to normal healthy adults, it can induce psychotic symptoms like hallucinations. This suggests that glutamate is basically required to counteract the psychotic symptoms like hallucinations. So, from this it has been inferred that there must be the deficiency of glutamic acid in the schizophrenic individuals. This is what results in the schizophrenia symptoms. This is all about the pathophysiology of schizophrenia. Thank you.